Welcome to session 13 of Foundations of Global Health. In this session, we will talk about mental health and cover basically the importance of funding work in mental health, the lack of support for global mental health in terms of facilities, doctors, and other individuals that work in the mental health field, and discuss the burden of mental health from a global perspective. So, first, let's look at global funding for global health. So, this is the FY or fiscal year 2021 requested budget allocation. And this is from the Henry J. Kaiser Family Foundation. And this is the global health requested total known funding provided by the State Department, USAID, CDC, NIH, and Department of Defense. And as you can see, this amounts to about $7.7 billion, and with less than 1% actually going toward um, mental health funding. And in fact, the next slide, we're going to break down this requested allocation a little bit more. When we look at funding based on sector for FY 2021, we can see that different priorities are well represented, including, for example, infectious diseases, including HIV, malaria, maternal child health, global fund, global health security, TB, family planning, reproductive health, nutrition, so forth and so on. However, we see that mental health, and I will show more slides to discuss the burden of mental health around the globe, is not well represented, and including NCDs, even though that we have shown in previous sessions that NCD funding and NCDs are significant. So this is a significant gap in funding that is not currently being addressed, even though $7.7 billion has been requested and is more than likely being allocated toward global health funding. So, mental health has been a significant issue in terms of the burden of it in global health. So, even in 2001, September 28th, the WHO published this, indicating that mental health disorders affect 1 in 4 people. And in fact, um, this was starting to, this was trying to shed the light on the burden of mental health in the global sphere. That's a health epidemic around us. Now, in 2019, again, the Guardian launched a series around the global epidemic on mental health. And they were also examining why there isn't enough awareness around this epidemic on the issue of mental health around the globe. This is unfortunate, but there is a significant issue around mental health in terms of stigma that many of us are aware of. And that issue, unfortunately, prevents a lot of people from seeking treatment. And also, unfortunately, it prevents many from, I think, being aware of this global epidemic of mental health. And in fact, I think COVID has exacerbated the issue of mental health disorders around the world. In addition to the Guardian commentary, other commentaries have attempted to shed light on the burden or the unrecognized epidemic of mental illness around the globe. For example, this commentary that was published in 2013. So there has been several attempts, but again, I think this has not really broken through the mainstream into the to the general public in terms of the epidemic of mental health. I think that only during COVID there has been at least more of a recognition that there is more now an issue around mental health. So, as stated, in terms of COVID has really sort of shed light on the mental health issue that has occurred or is occurring around the globe. And in fact, this recent publication that came out earlier in 2021 in Nature actually shows that, in fact, the pooled prevalence on mental health issues amid the COVID-19 pandemic has varied widely across countries and is higher than previous reports before the COVID-19 epidemic. The one thing that I will show you moving forward is that some of our data on mental health is not great in terms of our data collection due to the fact that there is stigma around mental health. However, we're starting to try and collect better data. But again, COVID has been a significant eye opener for a lot of individuals in terms of the mental health issues that exist within the borders of the United States and then again outside of the borders of the United States globally.
Jason Bradshaw says he loves teaching science in the classroom, and educating during the pandemic has taken a toll.
You feel like you're talking to a computer screen, and after several weeks of doing that, I think it really does start to get to you.
It's not only his mental health that suffered, he says, but his students as well. And while experts have warned of the havoc COVID-19, lockdowns, and fear would wreak on our psyche, a task force commissioned by the medical journal The Lancet instead uncovered a surprising shift.
Overall trends seem to show that by and large rates for psychological distress went up and then by and large went down.
Vancouver psychologist Lara Akkonen and her colleagues collected data from close to 1,000 studies across 100 countries. One poll in particular of more than 100,000 people worldwide revealed in 2020 most rated their lives on average as a 5.75 out of 10. The exact same score as previous years.
We aren't simply at the whim of viruses and any forthcoming natural disasters, but that we can mobilize, that humans can perhaps withstand these pretty drastic short-term alterations to our living styles.
But Akkonen says not everyone had the same experience. Individuals who faced financial hardships, contracted COVID, or those struggling with mental health disorders prior to the pandemic were more at risk. Harvard psychology professor Luana Marquez hopes to see a more in-depth study.
It's reminding us that it's not an all or nothing, and that perhaps the prediction of a tsunami may not be as large. I still think it's a little early to know long-term consequences.
Back in Brampton, as Ontario reopens, Bradshaw notes a positive change in his students and himself.
Ultimately, adaptation is part of the job when you're working with young people all the time.
Resilient, he says, and ready to return to in-person classes in the fall. Jamie Morocker, Global News, Toronto. Jason Bradshaw says he loves teaching science in the classroom, and educating during the pandemic has taken a toll.
You feel like you're talking to a computer screen, and after several weeks of doing that, I think it really does start to get to you.
It's not only his mental health that suffered, he says, but his students as well. And while experts have warned of the havoc COVID-19, lockdowns, and fear would wreak on our psyche, a task force commissioned by the medical journal The Lancet instead uncovered a surprising shift.
Overall trends seem to show that by and large rates for psychological distress went up and then by and large went down.
Vancouver psychologist Lara Akkonen and her colleagues collected data from close to 1,000 studies across 100 countries. One poll in particular of more than 100,000 people worldwide revealed in 2020 most rated their lives on average as a 5.75 out of 10. The exact same score as previous years.
We aren't simply at the whim of viruses and any forthcoming natural disasters, but that we can mobilize, that humans can perhaps withstand these pretty drastic short-term alterations to our living styles.
But Akkonen says not everyone had the same experience. Individuals who faced financial hardships, contracted COVID, or those struggling with mental health disorders prior to the pandemic were more at risk. Harvard psychology professor Luana Marquez hopes hopes to see a more in-depth study.
It's reminding us that it's not an all or nothing, and that perhaps the prediction of a tsunami may not be as large. I still think it's a little early to know long-term consequences.
Back in Brampton, as Ontario reopens, Bradshaw notes a positive change in his students and himself.
Ultimately, adaptation is part of the job when you're working with young people all the time.
Resilient, he says, and ready to return to in-person classes in the fall. Jamie Morocker, Global News, Toronto.
In the next series of slides, I'm going to talk about the burden of mental health disorders. Before I talk about this data, I want to just reiterate first 4 important things. First, mental health disorders are complex and take many forms. The data that I'm going to utilize in this PowerPoint presentation are going to be from the WHO's International Classification of Diseases, or ICD-10 codes, and these include broad definitions of mental health, including depression, anxiety, bipolar disorder, eating disorders, and schizophrenia. I'm not going to talk about all of these disorders, but use them as an example of mental health disorders to discuss the burden that exists. 2, mental health disorders remain widely underrepresented globally, and you need to keep this in mind when I talk about this data. It is true that across all countries, but particularly in low and middle income countries where data is scarcer, there is less attention and less treatment for mental health disorders. And there's also stigma attached to mental health disorders and also in high income countries. 3, this is very, very important. Figures presented in these next few slides should be taken as estimates of mental health disorder prevalence. They do not reflect diagnosis because, again, mental health disorders are underreported globally. So they should provide just a perspective on some of these disorders and are not the actual prevalence. But they are imputed from a combination of medical data, epidemiological data, surveys, and meta-analysis, including regression modeling, where raw data is unavailable. And of course, last but not least, this comes from the Global Burden of Disease from the Institute for Health Metrics and Evaluation from the University of Washington. So when we look at mental disorders or any mental disorder globally, and this is 2017 data, we see that that's represented among 10.7% of the global population based on IHME, or the Global Burden of Disease data. That's around, in 2017, around 792 million people. The frequency is 11.9% in females versus 9.3% in males. When we look at which mental disorders are more frequent in global populations, anxiety disorders is far more frequent, about 3.8%, which affects about 284 million in 2017, followed by depression, which was 3.4%, or 264 million, followed by, of course, bipolar disorder. However, any mental disorder or substance use disorder was around 13%, which was in 970 million individuals. So when we define mental health as any mental health disorder or substance use disorder, in that broad category, we see that we come out with a very different statistic. That is a far larger pool of individuals and is common around 1.7 individuals, or 15% of the individuals around the globe. And of course, you see here that depending on what country you live in, there's a higher frequency, anywhere from 20% to less than 20%, As I have stated earlier, this is not necessarily due to the fact that there is lower mental health or mental health issues in some countries. This is just because in some countries, mental health issues are less stigmatized and there is a better reporting system in those particular countries. So people feel freer to report their mental health issues and seek treatment for those issues, specifically in high income countries compared to lower middle income countries where there are no treatment available and there's a lot of stigma associated with mental health issues. The estimated prevalence of mental health and substance use disorders in 2017 affected over 970 million people. When we look at that category, we see that anxiety disorders indicated here in the dark green accounted for 3.76% of that large 970 million individuals, followed next by depression, then followed by alcohol use disorders in the yellow, followed by drug use disorders of all categories in the red, bipolar disorder in at point 0.6, and the red, blue, schizophrenia, and eating disorders at 0.21% in the dark blue. So this is the largest component of mental health and substance use disorders based on the data from IHME. In addition, we know that COVID 19 has also exacerbated many of the existing mental health disorders and the epidemic that was underreported, as I has presented earlier and as the video has shown. So we are only starting to begin to understand the impact of COVID 19 around mental health disorders, and we have not even truly begun to grasp the, uh, the amount of need around COVID 19, not only within the United States, but also around other countries, and especially within low and middle income countries. When we look at mental health disorders, we know that even though we have incomplete data, we do tend to see some trends. For data that we do have, we see that mental health disorders tend to be more common in women than men. This could be mostly due to maybe a reporting bias, but that seems to be the trend that we do see in the data. We see that on average, depression, anxiety, eating disorders, and bipolar disorders is more prevalent in women. That could be also skewed to the fact that we tend to see more data from high income countries than from data in low and middle income countries. We also see alcohol and drug use disorders are more common in men. And then also we have observed gender differences in schizophrenia prevalence are mixed across countries, but it's typically more common in men. So we're going to look at two specific disorders at the global level: depression and anxiety disorders. Both of these disorders cause significant burden to global populations. As you can see here, the chart that I showed previously, based on 2017 data, shows you the amount of significant burden they cause to global populations and their significant prevalence in males and females. First, depressive disorders occur with varying severity. According to ICD-10, depression is, of course, range from mild to moderate to severe. The data that I'm going to show you is based on the IHME burden of disease data. And in fact, they have disaggregated into mild, persistent depression or dysthymia, and major depressive disorders or severe. All forms of depressive disorders experience some of these following symptoms, which are listed here, which can include reduced concentration and attention, reduced self esteem and self confidence, ideas of guilt and untrustworthiness, and bleak and pessimistic views of the world, ideas or acts of self harm and suicide, disturbed sleep, and diminished appetite. So, for example, dysthymia or mild persistent depression is actually common in the US. More than 3 million people have it each year. It's very treatable by medication and by medical officials. It can require a medical diagnosis, lab tests, and it can be treated. It's mild but can also lead to a long term depression if it is untreated. The severe form of depression, which is called clinical depression or severe depressive disorder, leads to significant changes in sleep, appetite, energy levels, and concentration, even in daily behavior, self esteem. Severe clinical depression can be associated with thoughts of suicide. This is very common within the US and has over 3 million cases that have been reported. This is very treatable by medical professionals. It requires a medical diagnosis and can be resolved in months. So, as a form of major depression, it is something that, again, is very, very treatable. Globally, the number of individuals that suffer from depression varies from country to country, from anywhere from 2% to above 6.5%. Um, Individually, it seems that individuals that are over the age of 70 have a higher risk of depression. But again, this has to be with the caveat that we do not have a lot of significant information from low and lower middle income countries when we look at depression on a global scale. So some of the data that we have could be inaccurate in terms of our global estimates of depression because we're oversampled in terms of high income countries. When we look at the prevalence of depression of males versus females, at least based on 2017 estimates from IHME Global Burden of Disease, we see that the prevalence of depression in females is significantly more compared to that in males. The number of individuals reporting depression has increased by world region over the past 25 years. In 1990, globally, around a little bit over 150 million people reported depression symptoms. By 2017, over 264 million people estimated reported depression symptoms. This was probably attributable to number one, just a growth in the sheer population size. Um, Number two, less stigma around reporting depression. And number three, a greater estimation in terms of population level mental health to get better estimation of the sheer number of mental health individuals around the globe. As we have been able to better estimate the prevalence of depression given some of the limited data that we have around the world, we've also been able to better um, estimate that age adjusted or age standardized disability adjusted life years on depression for 100,000 individuals um, around the globe. And this is, of course, global burden of disease data. Again, this is data based on some of the information that we have in terms of information in low and middle income countries. These are estimates. We do not have a lot of good information in low and middle income countries because they do not have some of the best surveillance systems for mental health, specifically around depression. But these are some of our best guess estimates. Our estimates for depression within the United States and other high income countries are a little bit better since they have a stronger mental health system. Anxiety disorders are another mental health disorder that causes a significant amount of um, burden in terms of mental health disorders for global populations. These arise from a number of forms, including phobic social obsessive compulsive disorders, or OCD, post traumatic disorders, or PTSD, or generalized anxiety disorders. These are actually very common, and there are more than 3 million cases per year. They can be treated by medical professionals. They're usually self diagnosable, and lab tests or imaging are not required. And they usually have symptoms that are usually three main symptoms. They recall or involve apprehension, motor tension, and autonomic overreactivity or overactivity. The prevalence of anxiety disorders across the world varies from 2.5 to 7% by country. And in fact, we know that in countries where there are robust healthcare systems, mental health systems, that the anxiety disorders are more around 7%. However, in countries where there are no reports or very, in terms of hardly any reports about anxiety disorders, those tends to be countries, low middle income countries here in Africa. Those tend to be lower. But we know that these prevalence rates are probably not as robust um, because of just that this is modeling data. Although this is 2017 data, um, the prevalence of anxiety disorders tend to be greater in females versus males. But again, we have to acknowledge that we don't have a lot of data in low and middle income countries, even though we have some plots here. So if the more data that we have, maybe this chart might change. So when we look at anxiety disorders, we see that anxiety disorders increase with increasing age to the age of 50 to 69. Then after 69, actually it decreases. So when you see 70 years old and plus, you actually see that their anxiety disorder is significantly less than those individuals that are in the 50 to 69 category, which is quite an interesting finding here. And finally, bipolar disorder, termed bipolar affective disorder, is defined by the ICD-10 code as characterized by at least two episodes in which a patient's mood and activity levels are significantly disturbed. This disturbance consists of, on some occasions, to be elevation of mood and increased energy and activity, and on others of a lowering of mood and decreased activity and energy. In fact, bipolar disorder is very common with over 3 million cases in the US. Treatment can help with this condition, and it can't, but it cannot be cured. It is chronic and can last for years or even for a lifetime. It requires a medical diagnosis, um, um, but it does not, lab test or imaging is not required. Globally, bipolar disorder is showing to affect around 46 million people based on 2017 statistics, and it affects relatively um, about 0.65% of females, 0.55% of males.
As a global community, we've been quiet. Depression and anxiety disorders affect more than 600 million people around the world. For people suffering, everyday tasks can be difficult. So what are the roadblocks that prevent countries from addressing mental health? Stigma, inadequate funding, and poorly prepared health systems. The cost of lost productivity in the workplace due to depression and anxiety is very high too, over $1 trillion per year. But we also know that treatment for depression and anxiety is a worthwhile investment. Every dollar invested in treatment leads to a return of $4 in better health and ability to work. But governments in low-income countries spend less than 1% of their health budget on mental health. High-income countries invest around 5%. This is a critical time. Globally, only 1 in 5 people who need treatment for depression and anxiety are receiving it. Almost half of the world's poor are expected to live in a country affected by war and violence by 2030. Refugees and people living under such stressful conditions are at an even higher risk for mental health disorders. We also know that such traumatic events can have a major impact on a child's or adolescent's brain development and lasting effects on their health well into adulthood. Without action, the impact on people's mental health is likely to be on a scale we have never seen before. We can solve this by scaling up the work already underway and strengthening political will and leadership, integrating mental health into health systems, and increasing investments from national governments and international development partners. Let's bring this issue out of the shadows. It's time to make mental health a priority now.
So, as I have shown that at least the burden of mental health is significant around the globe. It's an epidemic that has been unaddressed. The WHO has undertaken a strategic initiative to try and at least characterize what countries are doing. They came out with a publication in 2017 called the Mental Health Atlas, which hoped to characterize what countries around the world are doing to address mental health. Of the member states, the 194 member states from the WHO, 177 at least partially completed it, or many fully completed it. Which was a response rate of 85%. The results are here in 5 uh, bullet points, basically. It provides a global reporting on core mental health indicators. It talked about mental health system governance. It also talked about finance and human resources for mental health. It discussed mental health service availability and uptake, and it also finally covered mental health promotion and prevention in all of the WHO regions. So the first major question um, or set of questions that were asked about the Mental Health Atlas from the WHO was around compliance of mental health policies and plans with human rights. And this compared the respondents from 2014, when this survey was first administered, with that of 2017. So the first question was, were there actually policies and plans to promote transitions toward community-based mental health services? In 2014, which is the light green, the member states reported only 92%. In 2017, dark green, 97%. Um, for the second one, policies planned to explicitly pay attention to respect for human rights of people with mental health disorders. That rose from 85 to 89%. So basically, in all these categories, the member states stated that they have policies and plans, for example, to promote a full range of services, the support to enable people to live independently and be included in the community, went from 76 to 81. Policies and plans to promote a recovery approach to mental health care, that went from 76 to 89. And of course, policies and plans to promote the participations of persons with mental health disorders in decision making process, which went from 86 to 80, 68 to 82%. So overall, the WHO member countries are making policies and have plans to address all of these structural defects in terms of mental health within their countries or regions. So the last slide showed that there are policies and plans, but you can have policies and plans. It is the importance of the resource allocation. So the first set of slides is based on WHO World Region and then the World Bank Income Group, low income, low middle income, upper middle, and high income based on the respondents. And the first categories are the number of countries and then the percent. So this talks about countries reporting that estimates of human or financial resources are contained in the mental health policy plan. So these countries reported that, of course, that those actually had financial resources contained within those policy plans. And then this actually says countries reported that resources have been allocated in the implementation in line with human or financial resources contained in the mental health policy plan. So this actually shows a significant commitment because there's a budgetary item. So when we actually look at the commitments for countries in terms of actually allocating money, we see that in low and middle income countries, there's only actually 21% that have actually allocated resources toward implementation of financial resources in mental health policy and plan. Compare that to specifically lower middle income countries, which is 53%, upper middle income countries 63%, and high income countries 70%. And then here are the different regions. In the African region, it's only 27%, and then the various other regions which had a higher allocation of resources for implementation. We can also look at government mental health expenditure per capita based on US dollar by WHO region. And here are the WHO regions just to help in terms of identifying which regions are. And we can see that the lowest per capita spending are in two regions in which you had 10 and only 5 respondents. So the Africa region was zero point 0.1 in terms of spending, and also the Southeast Asian region, which was also zero point 0.1, was significant in terms of their low spending on mental health, followed next by the Western Pacific region in terms of their per capita spending. Of course, the European region has significant and had the highest spending in terms of mental health. Now, it might not be a surprise to anybody, but the two regions that had the lowest spending per capita on mental health, if we look at it by WHO region, also had the lowest in terms of mental uh, health workforce per 100,000 per population. So in Africa, it was zero point 0.9, and in the Southeastern Asian region, it was 2.5. By far, Africa had the worst And this was, of course, a sample size of 37 countries reporting for this one, and for this one, it was 10 countries. Now, we can do the same, or WHO did the same, and stratify by the the World Bank income group based on low, lower middle, upper middle, and high income. And it showed that in Africa, it was actually 1.6 workers per 100,000. And in lower middle income, it was 6.2, upper middle, it was 20.6, and high income, it was 71.7. So, again, there's a correlation between spending on mental health and workforce. And the 2017 data also, in fact, looked at the breakdown in terms of at least WHO region in terms of medical workforce, looking at it based on psychiatrists, child psychiatrists, other specialties, psychiatric nurses, psychologists, social workers, etc. And of course, it showed that in some job categories, they were less than one person per 100,000 individuals. And in some job categories, there were even no individuals available at, uh, in, in at least the African region, based on the 32 countries that responded at that time. Of course, the Eastern Asian region was a little bit better in terms of statistics. And of course, the European region and other regions had a lot better statistics. And then, of course, this is World Bank income categories. And of course, when you look at those statistics again, it's even a little bit more, looks a little bit better in terms of at least having some categories that are filled. But again, there's still significant disparities in terms of income levels, in terms of mental health workforce. So although um, all the countries reported that there were plans and policies for community-based residential care facilities, when uh, the data was available in terms of how many hospital beds, residential beds, units, etc., mental health hospital beds, based on world regions, actually, the data was much different. So the policies are in place, uh, but resources have not been allocated, and actually, the infrastructure for mental health is non existent. Again, the African region is by far the least in terms of mental health beds, psychiatric beds, and in fact, for child and adolescent beds, residential care beds, they're almost non existent. Other regions are doing a lot better in terms of beds that are available for various individuals and various different types per 100,000 individuals based on WHO region. What the Mental Health Atlas has found for 2017 is that number one, the mental health beds per 100,000 populations is below 7 in lower middle income countries and is over 50 in high income countries. This is a significant disparity. Equally large disparities exist for outpatient services for child and adolescent services, and social support are significantly lacking in low and middle income countries. The median number of child and adolescent beds is less than 1 per 100,000 in populations low and lower middle income countries, and is below zero point 0.2 in lower middle income countries, and is over 1.5 in high income countries. Moreover, 123 countries is equivalent to 69% of the countries who responded, or 63% of the WHO member states, have at least two functional national multi-sectoral mental health promotion and prevention programs. Of the almost 350 reported functional programs, 40% were aimed at improving mental health literacy or combating stigma, and 12% were aimed at suicide prevention. So there's a lot to be done in terms of mental health, but it also requires a lot of resource allocation, which is not occurring in low income countries, which it needs to occur, which there is not a significant workforce to address much of the mental health issue that exists. The time to act is now, as stated by the WHO, to empower communities and individuals to attain the highest standard of health, which can be achieved only through when their mental health and well-being is ensured. And this is basically the vision for the universal health coverage for mental health, which is a WHO special initiative for mental health for all people to achieve the highest standard of health. So the WHO or the WHO plans to implement this for mental health over 5 years, and the WHO plans to raise around $60 million to for this special initiative. This next special initiative for mental health will, will advance mental health policies, advocacy, and human rights, and scale up quality interventions and services for individuals and mental health conditions, including substance use and neurological disorders. For continued scale up and global learning, the WHO will implement this work in 12 priority countries, working with partnerships with member states, local and international partners, as well as organizations of people with lived experiences. It is going to be through basically two strategic actions. Strategic action one, advancing mental health policy, advocacy, and human rights. Strategic action two, scaling up interventions and services across community based general health and specialist settings. The initial target is by 2023 to access mental health care for 100 million more people. And this is the mechanism in which has been stayed out for WHO. In addition to expanding universal health care for 12 priority countries, the WHO also is working with primary health care centers, or PHC, in terms of identifying three strategic areas of work to strengthen PHCs around the world for mental health care. Number one is providing a one stop mechanism for PHC implementation to support member state tailored to country context and priorities. This includes putting into action operational framework for PHC um, in the area of mental health. Number two, producing PHC oriented evidence and innovation with a sharper focus on people left behind. Key deliverables include monitoring the measurement and guidance to assess PHC progress in country, subsequently a global report on PHC progress, as well as innovation capacity for building efforts, part of the WHO Academy. And this will be focused, of course, to include mental health. And last but not least, promoting primary health care renewal through policy leadership and advocating strategic partnership with governments, non-governmental organizations, civil society organizations, development partners, UN sister agencies, donors, and other stakeholders, which are basically what the WHO does best in terms of primary health care and also thinking about it from a mental health perspective.